So my talk today is focused on the impact of MASLD and outcome in cured SCV patients. And here is my disclosures. In our study, first discuss the relationship between the MASLD and SCV, and second, the dynamic change of MASLD before and after viral cure, and third, the role of MASLD and cardiometabolic risk factors on hepatic and extrahepatic outcomes following viral cure, and fourth, on medical need and summary. And first, I briefly introduce the relationship between the steatotic liver disease and SCV infections. So in addition to cause chronic hepatitis and even cirrhosis, hepatitis virus can directly increase the risk of liver steatosis through altered intrahepatic signals. This is particularly for genotype 3 infections. On the other ways, hepatitis virus can indirectly abort the host metabolism, including obesity and diabetes. The increased insulin resistance will further promote the risk of liver steatosis. So the current epidemiological studies have found that among patients with active SCV infections, the overall prevalence of MASLD steatotic disease is about 55%, spanning from 40 to 86%, which is much higher than the poor prevalence of MASLD, about 30 to 38% in the general populations. So here I show a study from Taiwan showing which includes 95 patients with active HCV infection who received a liver biopsy. By histological analysis, as high as 47% exhibit signs of hepatic steatosis, which was consistent to the global report of steatotic liver disease. And how about, because hepatitis C virus will increase the risk of steatotic liver disease, how about the dynamic change of MASLD before and after the viral cure? So here I summary various studies in the era of MASLD and MASLD. So while some studies have proposed that after the viral cure, there have an improvement of steatotic liver disease, particularly using the liver biopsy as gold standard. You can see that very clearly. In genotype 3 infection, there have a 91% of steatotic liver disease due to decrease to only 39%. For non-genotype 3 patients, they have a decreased trend of 43% to 34%. However, some studies did not find a trend of decrease in the liver steatosis or no change of prevalence or even increase prevalence of steatotic liver disease following the viral cure. And now, are there any difference between the MASLD and MASLD? So I proposed two independent studies from the United States using the different database. All the two studies have shown that there is a high concordance rate between the patient with the diagnosis of MASLD or MASLD to as high as 99%. So we can use that the MASLD or MASLD are exchangeable terms in the literature. So in the era of MASLD, how about the dynamic change of MASLD following the viral cure? Here I demonstrate a recent published paper in Taiwan in TASL research school database of enrolling a sizable number of more than 8,500 patients with SCV cure. They use the liver ultrasonography as a gold standard to denote the presence or absence of steatotic liver disease. And they define the 6 months after viral cure at the endpoint of follow-up. So the endpoint of study of change of prevalence rate of MASLD before and after viral cure, the proportion of MASLD regression or emergence, and last the factor associated with the MASLD regression and emergence. Before the antiviral treatment, about 34% of this patient exhibited MASLD. However, at the end of 6 months after the viral cure, the prevalence rate would not change to denote the 34.8%. So among the patients with MASLD at the baseline, as high as 28% of these patients exhibit MASLD regression following the viral cure. On the contrary, among patients without the MASLD at the baseline, as high as 15.4% of patients exhibit emergence of MASLD at the endpoint of follow-up. So the group defined that's interesting. Regardless of MASLD emergence or resolution, there the BMI is a key player to affect the MASLD emergence or resolution. Additionally, A1C level that denote the hyperglycemia or high LDL cholesterol are associated with the MASLD emergence. So because that liver ultrasonography has low sensitivity to detect the early stage of liver fibrosis, so our team have conduct another study at 10 academic centers. We enrolled about 1,500 patients for patients with viral cure using direct antiviral agents. Instead of using the liver ultrasonography, use the FibroScan with a cutoff level of 248 as to denote the presence or absence of liver steatosis. So the endpoint was quite similar between these two studies. So here are our data. So our data was slightly different from the TASL cohort. We found that before the viral treatment, 45% of these patients exhibit the MASLD. So quite similar to the liver histology analysis around different countries. So at the end of follow-up at the time point of SBR12, we found that about 9% of decrease of MASLD as compared to the pre-treatment status. That's quite consistent to the prior study in European country using the liver biopsy as the gold standard. So among the patients with MASLD at baseline, we found that about 21% of patients exhibit MASLD regression. However, among patients without the MASLD at baseline, we found that only 1.1% exhibit emergence of MASLD at the endpoint, at the time point of SBR12. So it's quite different from the TASL database. So specifically, we are looking into the change of CAP levels in the entire population. We found that at the time point of SBR12, there's about 8 decibel per meter decrease of CAP as compared to the pre-treatment status. When we break down to the patient with or without MASLD, we found that we had a similar trend of decrease of CAPs, about 10 to 11 decibel per meter at the time point of SBR12 as compared to the pre-treatment status. So how about the risk factor to affect the emergence or regression of MASLD before and after viral cure? In contrast to the TASL cohort, we found that the type 2 diabetes is the key player to determine the emergence or absence of MASLD. In contrast to the TASL, we found the BMI level as the key player. So additionally, we found the age more than 50 years or ALT level less than 2 times the upper lower limit were associated with MASLD regression. So here is the schematic representation of the viral clearance, the effect on the steatosis. Following the viral clearance, a lot of intrahepatic signals that promote the liver steatosis will be mitigated or aborted. That promote the favor the MASLD regression. However, following the viral cure, there is a decrease of hepatic systemic inflammation just through a very complex neuropsychiatric modification of genetic predisposition that will make some patients will have a body weight gain or increase intake that will worsen the liver steatosis, that will increase the risk of MASLD emergence. So the next is how can we explain a divergent result from various studies? So it can be attributed possibly to the heterogeneous characteristic of the recruited patient, which some of them significantly affect dynamics of MASLD. And secondly, the adoption of diagnostic tools such as fibrinogen elastography, liver ultrasonography, or MRI PFDT may affect the outcome of the estimate. And lastly, the duration of the follow-up following HCV cure divergent. So the third one is how about the role of MASLD and its cardiometabolic risk factor on the hepatic and extrahepatic outcomes. So with the now in the era of pan-genotypic direct antiviral agents, so almost all the patients can have a cure of a viral cure, reached a viral cure following a very short duration of antiviral therapy. So that makes a risk decrease to about 80 to 85% regarding to liver-related mortality, liver decompensation, or SCC. However, a small proportion of patients still exhibit a grave liver-related outcome that make us to investigate which is the key player to affect long-term grave outcomes. So today I will specifically focus on the presence of liver steatosis. Here a study have shown that following the SVR12, the presence of steatosis have about 7.51-fold time-dependent risk as compared to those without signs of liver steatosis. And the factor hold true when the authors break down the baseline fibrosis stage as advanced or not. There have some effect to affect longer outcome, including all-cause mortality and SCC. So regarding to cardiometabolic risk factor, now we found that the present type 2 diabetes unequivocally to be associated with a grave outcome, including the SCC, de novo recurrent SCC, cirrhosis, decompensated cirrhosis, or overall mortality. However, regarding to body mass index, there are equivocal role with no increase or equivocal the effect on the long-term outcome in these patients. So recently another study that have put the fatty liver disease and cardiometabolic risk factors such as diabetes into the multivariate variable analysis to see if there would affect the risk of de novo SCC. They found that the patient using a direct antiviral or packaging from ribavirin, both steatosis and the present diabetes will concomitantly affect the long-term outcomes. But now we moved in the era of MASLD that have two prerequisites of steatotic liver disease and cardiometabolic risk factors. So the next question is, how about both factors that affect long-term outcome, particularly SCC occurrence? So do you have any mediation effects between the cardiometabolic risk factor and steatotic liver disease, or they independently affect long-term outcome? So based on the unmet medical needs, we recently conduct a study retrospective analysis of a prospective cohort enrolling about 1,600 patients with MASLD or not following a viral cure. So in the study, we also adopt a cap with the cutoff of 248. And similarly, we found the prevalence in MASLD is about 42.5%. And very interesting, we found that over 99% of patients with a diagnosis of steatotic liver disease will also exhibit MASLD. So with a median of follow-up of 5 years, that we have estimated the over entire population, the crude instance of SCC about 144, and the schematic research show that among patients with MASLD at the time point of SVR exhibit a significant higher risk of SCC as compared to the non-MASLD counterparts. So furthermore, we do a very sophisticated analysis. You can see that, not surprisingly, in univariate analysis, in addition to conventional factors such as age, sex, abigrade, alpha-fetoprotein, and LT levels. So the MASLD and steatotic liver disease and type 2 diabetes, the cardiometabolic risk factor, hypertension, and the waist circumference also affects the risk of de novo SCC infection. So we build various multivariable models. But in model 1, we put all the covariant in the analysis. So in addition to conventional predictor, we found that if we put steatotic liver disease and cardiometabolic risk factor into the models, so the presence of MASLD outweight or cardiometabolic risk factor to be associated with the risk of de novo SCC. The second model we use is static steatotic liver disease instead of MASLD to denote that you should see that the time-dependent hazard ratio were quite close because 99% of these patients had overlap diagnosis. And finally, we exclude the cardiometabolic risk factor because they had high collinearity with steatotic liver disease. We found that the presence of MASLD had a twofold increase of time-dependent de novo SCC in this model. So next, we do the sensitivity analysis to take into the competing risk into analysis. We found that after just before the competing risk, we found that the model is quite stable. There about a twofold increase of de novo SCC occurrence among patients with MASLD as compared to the non-MASLD counterparts. And the next step is we want to discuss are there any mediation effect between the steatotic liver disease and cardiometabolic risk factors? So we do the detailed and complicated mediation analysis, which show that the MASLD mediate all cardiometabolic risk factors on the development of SCC. So very interesting, type 2 diabetes has also had direct effect on the SCC occurrence. So there's very important that type 2 diabetes is the key player to the development of SCC. So based on our study, we found that these figures show that MASLD mediate all cardiometabolic risk factors for the SCC occurrence. So very interesting, how can we mitigate the risk of SCC among patients following the SCD cure? So firstly, the lifestyle modification and use of drug therapy to control the cardiometabolic risk factors. Additionally, such as GLP-1 also can reduce body weight, alleviate lower agent and hypertension drugs. Additionally, some studies found that use of metformin statin that would directly affect intrahepatic signals. That is why we have found a direct effect of type 2 diabetes on the occurrence of SCC. That's quite important. Lastly, the new drugs risk material that directly change the microenvironment of the liver may potentially reduce the SCC among the patient masses. So it is a target for reducing SCC in the future. So the last little, how about extrahepatic manifestation MASLD following SCD cure? We found that this study showed that following a viral cure, a patient with concurrent liver steatosis and dyslipidemia that could fulfill the criteria of the MASLD that have a higher post-treatment level, increase the level of small dense LDL cholesterol that is highly correlated with cardiovascular risk. So are there any unmet medical needs? So the unmet include the dynamic change of steatotic liver disease and cardiometabolic risk factor with an even longer duration of follow-up. So we still don't know if a very long time of duration of follow-up there is any direct change of steatotic liver disease in the long run. So another one is we should validate and further explore the current evidence regarding the role of MASLD and various hepatic and extrahepatic outcome because the study paper till now is only very limited. And the third one is the role of severity of hepatic steatosis as well as number, character, or grade of cardiometabolic risk factor on the post-SBR outcome. And lastly, the estimated SCV surveillance for different stages of hepatic fibrosis under the presence or absence of MASLD. So in summary, so SCV is associated with increased risk of hepatic fibrosis directly or indirectly. So the dynamic change of the data regarding to the dynamic change still remain disputed, probably attributed to the divergent design across studies. And about the MASLD outcomes, now we found that steatotic liver disease and type 2 diabetes animals increase the risk of poor hepatic outcomes, and MASLD mediate all cardiometabolic risk factor for de novo SCC development. And finally, apart from MASLD mediation type 2 diabetes and partially the dyslipidemia has direct effect on SCC development. And lastly, how about the extrahepatic outcome? There is still limited data available now with MASLD and dyslipidemia tend to associate with cardiovascular risk. Thank you for your attention.